So the subject today is opioid use disorder and pain, chronic pain management, in addition to acute pain management in the setting of opioid use disorder. As I said, I'm a staff physician here at the Mountain Home VA. Okay, so I have no disclosures other than I'm a federal employee, and the ideas and opinions presented today are that of my own and don't reflect that of the federal government. Many of my slides have been adapted from two of my mentors, as well as from PCSSnow.org, which I'll explain in a second. It's a good resource for learning not only OUD treatment, but also chronic pain management. So a special thanks to AJ Monhapra, who gave me some of his slides. He's a addiction medicine board certified internist as well. He works at the Hampton VA and is also a professor at Yale Medical School. Dr. Sanel Bott from Project ECHO in the University of New Mexico. Obviously, we're a Project ECHO descendant. They are an amazing program that also provide a number of different webinars that I recommend people join. They have a really good one about COVID right now. But I've been participating with Project ECHO ever since medical school, and this is how I achieved much of my training in chronic pain management as a family medicine resident, and then later on after practicing on my own. Dr. Bott is a addiction psychiatrist, and he also works in the pain chronic pain management ECHO. So PCSSnow.org is a national training program. It's a clinical mentoring program that has been developed in response to the opioid use disorder crisis. They provide MAT waiver training in addition to pain core curriculum. And they offer a lot of CME offerings. So the objectives today are to describe the evolving chronic pain paradigm. So the chronic pain paradigm is changing, and we'll describe how it's changing and how we understand chronic pain. And then additionally, we'll look at a comprehensive approach to chronic pain management. So in treating folks with OUD, we basically kind of use the same paradigm and framework in treating chronic pain, with some nuances with some of the medications in both acute and chronic pain settings. We'll describe the relationship of chronic pain in OUD, and then we'll look at strategies for certain situations for treating people with OUD when they're on medications for OUD. So the conventional pain model that is now changing is one in which really acute pain and chronic pain have been kind of analogous. We get an acute pain injury in a certain location, and then we get pain at that site that's then transmitted up to the brain and felt in the brain. And then ultimately this leads to distress. And then in the acute setting, acute pain is actually protective, and we modify our activities and protect. But ultimately, this leads to a short-term disability, and hopefully after that injury has been healed, then we kind of move on to normal function. Now, chronic pain is this idea that in the old paradigm, this persistent injury continues. And so we get continued pain being sent up the spinal cord to the central nervous system, and then, felt, or peripherally to the central nervous system and then felt, causing distress, and then ultimately causing physical disability. And so where this is really changing is this idea that really chronic pain, after about 3 months, the injury for the most part has been healed. And so the idea now is that the new pain model is that after the acute injury is suffered and healed, then really the noxious stimuli is over. And so you're not getting this ongoing noxious stimuli. And really then what happens is that the signal ultimately takes on a characteristic of its own and becomes amplified and modulated in a way that really is not alerting the system that there's ongoing damage, but now the signal is aberrant and amplified, and that ultimately generates a healing response that is maladaptive, and that would be, poor pain coping strategies, poor, the idea of catastrophization, activity modification and limitation. And so we're not moving and we're getting kind of stiffer and we're losing muscle mass. And then ultimately this leads to more disability. And so really the idea is that, you know, we want to address the maladaptive behaviors, and this is not ongoing threat. It's a difficult paradigm even for me to really sink in the setting that, you know, even in chronic pain, you know, with many of our interventions, we do go after these pain generators. And some of my main consultations is to really find, hey, what is the pain generator? And so, you know, we still are stuck in this old paradigm and we go after these pain generators. But in general, the thought is that, you know, really chronic pain takes on a signal of its own, and it's not necessarily the noxious stimuli. But as I mentioned last week in the presentation, I had just seen a gentleman who is 375 pounds and has bone-on-bone osteoarthritis. And it would be hard to argue that there's not ongoing damage and, you know, bone-on-bone, and that arthritis is worsening. And so it's not to say that we don't pay attention to some of these pain generators, but I don't think that it's the focus. It's really that now the focus of all the things that go along with chronic pain and the impacts with the psychosocial factors, the medical illnesses that get worsened by inactivity, the psychiatric disorders that can come on, depression, anxiety, and then ultimately dependencies that can come on with some of the medications that we might choose to use. And then unfortunately, with many different specialists, we ultimately get to a situation in which the kitchen sink is thrown at them and they might have polypharmacy that can lead to further disability. So really kind of the takeaway point here is that it's not just the pain generator, and that there's other more maladaptive situations in which we need to address. This is really just kind of the same thing of the spectrum of, you know, once we have the acute event, then leading to more of these kind of maladaptive features that ultimately can lead to substance use disorders as one of the problems. So this new paradigm and ways to treat pain is then looking at the biopsychosocial approach, mind, body, spirit, and really looking at ways in which we can impact not necessarily the pain score. This pain score is really, I think, what some of the problem was with kind of the development of the opioid crisis, at least with respect to kind of overutilization of opioids in the setting of chronic pain. And so what we try to do now is we attempt to increase function. Function is the main name of the game. And then ultimately, to a lesser extent, but still important, is decreasing suffering. And we do this through the primary tier is this self-management, and where we really look for non-pharmacologic measures in order to increase that function. And then we also use pharmacologic modalities as well, which we'll get into. So self-management is the first tier, as I said. Exercise and movement is the main key. We want to decrease the overall inflammation, whether that be decreasing in weight and weight-bearing joints, you know, kind of unloading them, and also the burden of just being overweight and having the adipocytes kind of creating some of this inflammatory milieu. We want to lengthen and strengthen muscles. I say one of my modicums is, you know, if you're not moving, you're not getting better. And then smoking cessation as a form of chronic pain treatment. You know, the smoking certainly leads to an inflammatory burden as well that can ultimately lead to kind of further pain sensation. The non-pharmacologic measures that we often encourage trials of and include acupuncture, chiropractic care. Myofascial trigger point release is one thing that I really enjoy doing and find it very effective. And that can be with manual compression that's done by the patient, or it might be more interventional style where you're putting in dry needles and acupuncture needles into these muscle knots to deactivate these trigger points. You can also inject lidocaine. Pain psychology, I think, is the mainstay of some of the interventions that we offer, and I think are the most important. Last week, there was a question about specific styles of cognitive behavioral therapy. I don't have a specific style that I can recommend other than the VA has their own CBT for chronic pain that is utilized. ACT therapy, acceptance commitment therapy, is another big one. My wife is a pain psychologist, and she really finds that one of the most important, and that kind of works with values and how a patient and that how that fits into their lives. Pain coping strategies is another big one, and in that, really kind of focusing on not only activity, but also activity limitation in the sense of pacing. We have a really good pain program here, functional integrated physical therapy, really looking at the neurophysiology of pain and really getting, again, patients moving in ways that they will likely do at home. So it's not a one size fits all, but often what we're trying to do is, get that core stabilization, core strengthening, and lengthening muscles. And then, of course, we have these advanced interventional procedures that go after that pain generator, right? And so we still do the epidural steroid injections, which is an injection into the epidural space, diffusion of steroids into the area, and hopefully a calming down of some of the inflammatory process. The set blocks are into the joints in the vertebral column. And then if those work, we can ultimately burn some of those nerves with radiofrequency ablation. You can go all the way to dorsal column stimulators. You can do pain pumps, and these are done, and they can help, but these are not a fix. These are not a cure. These are, again, bridging therapies. I'd like to say that all of these therapies that we're putting forth here in the non-pharmacologic adjunctive therapies are bridging. That we're bridging to get then that first slide with the self-management. We need to get them moving. We need to get them kind of owning their pain and really treating a lot of their pain on their own. So with the pharmacologic options, the non-opioid options, we have the tricyclic antidepressants that can be very helpful. We do have to be careful in using tricyclics in the elder population. We usually use very low dose at night. This can help with sleep, can help with some of the neuropathic pain that we might see in peripheral neuropathy from diabetes or otherwise. The next group is the SNRIs, serotonin norepinephrine reuptake inhibitors. These are medications such as duloxetine, venlafaxine that can be effective, but one thing to know about them is that at lower doses, SNRIs really function as SSRIs and really just hit the serotonin system in order to get the noradrenergic modulation, which is what we think really helps with some of the what we call the descending pain modulation factors is achieved by higher levels. So with duloxetine getting up to 60 milligrams, with venlafaxine getting up to 225 milligrams. For the most part, well-tolerated. Duloxetine can cause some nausea and diarrhea. We do have to be careful with hepatic disease with duloxetine and some renal dosing as well. The next class that has been, a pretty mainstay of treatment is the NSAIDs. And often, we get legacy patients that have been on meloxicam 15 milligrams every day for 20 years. And this is really not the way I prefer using these medications. One of the main concerns right now is the cardiovascular effects, not to mention the renal and GI comorbidities, but increases the risk of heart attack and stroke. And so the way I use these, I always try to use topical over oral. The topical really has very limited systemic absorption and therefore really not getting these risks. If the topical is not enough, then we can move on to oral. I will say that the topical primarily is used on smaller joints, ankles, knees, maybe some hips, not necessarily as much in the low back or the neck, but certainly, there's no harm in trying some of these other areas. And, some patients really do find it helpful. You generally apply it up to 4 times a day. The next class of medications that we've heard about are the gabapentinoids. There's some concern that there can be abuse potential in the setting of OUD, and so we do have to be aware of that. But I think overall, they can be good adjuncts and in some senses opioid sparing, and maybe allowing us to use either no opioids or less opioids, generally in the setting of peripheral neuropathy or maybe some central kind of sciatica type situations in radicular pain. Capsaicin cream is a medication that can be cumbersome to use. It's a substance P depleter. Substance P is a transmitter that transmits the signal of kind of more of the neuropathic pain. And what we try to do with capsaicin derived from a chili pepper is that we apply that 4 times a day for at least 2 weeks. And then we've now used up the substance P, in a sense, jamming the signal and interrupting the signal, and can be quite effective when it works. Often I'll use it in post-herpetic neuralgia Again, it can be difficult to use, and you got to be careful about after application, really washing the hands or using gloves so that you don't get it on the genitals or on the face and have bigger problems. Muscle relaxers are often used, I think, too much. Again, kind of these legacy prescriptions that just keep on getting renewed. These really should be for short-term pain exacerbations and really not kind of a chronically, used, like the classic one, cyclobenzaprine, is really very similar to a TCA, and we can have problems with their kind of long-term use. So short-term exacerbations, getting over the exacerbation, and then kind of moving away from using it daily. So now we go on to opioids, kind of the elephant in the room in the last 10 to 20 years as far as chronic pain management. Really was the mainstay around the 90s and the early 2000s, and now finding that, we really can develop some problems. One of the main problems is that they're often just not very effective in treating chronic pain. And when the name of the game is function, we see that really there's not a lot of function gained. And if anything, oftentimes function can be lost with opioids. And so the CDC came out with the guidelines, I think 2015 maybe. And in those guidelines, or maybe even earlier, in those guidelines, that was primarily for primary care physicians. And so the idea is that really there's a whole risk-benefit analysis, and that it's not to say that we can't use opioid medications, but really we should use them responsibly and in the setting of doing this risk-benefit analysis. So, a lot of times I'll look for opioid-related risk factors, whether it be untreated sleep apnea or even treated sleep apnea can be a problem with exacerbating that sleep apnea and causing respiratory depression. Advanced age over 65, there's some concerns about the metabolism of opioids and further complicating that risk. Certainly, a history of any kind of substance use disorder can lead to the development of opioid use disorder in the setting of opioids. VA-DOD guidelines came on afterwards. They're a little bit, I think, even more stringent with respect to opioids and really kind of being concerned even starting opioids on younger folks, especially in the setting of mental health comorbidities like PTSD, even smoking in that setting can really lead to kind of worsening outcomes. So again, when we use the opioids, we're not looking at the pain score. If we just chase that pain score, we're going to be escalating doses and probably not getting anywhere. Really looking at, increasing function. They are, certainly affect anesthesia and cause a reduction in pain both centrally and peripherally. But there's also this idea of decreasing suffering that we see in the limbic and reward center. And so that's a lot of some of the overlap that can occur in the development of opioid use disorder. And, you could argue that decreasing suffering isn't a bad thing, but some of the other things that can come with the development of OUD then, can become problematic. In general, the guidelines say that, you really want to avoid going over 90 milligrams morphine. I really stay pretty hard and fast on that goal and really try to get people down at least to that level or lower. Really what we see is some different steps in risk. The first risk step goes over 50 morphine equivalents and then later over 90. And just a simple kind of calculation as for morphine equivalents, we're just basically comparing apples to apples, right? So morphine is the standard that we compare against everything else. And so hydrocodone, for example, is a 1-to-1 relationship, whereas oxycodone is a 3-to-2 relationship. And this has to do with the amount of stimulation that occurs at the mu receptor. Fentanyl much stronger, methadone even stronger, and having a kind of a difficult calculation as far as lower doses, kind of a less MEDD, whereas higher doses can be substantially higher in the MEDD calculation is not 1-to-1. So then we get into now OUD. In the setting of chronic pain, the prevalence of chronic pain in OUD is quite high, ranging in these studies from 37% all the way to 64%. I would say that it's probably on the higher end. I think, and you could argue why that is. It could be, the life leading up to OUD and development, I think certainly, leads to one of injuries and other medical comorbidities that can contribute to pain, including hepatitis C that can cause pain in and of itself. So I think it's fairly common, and we need to address chronic pain. It is bidirectional as well, pain and OUD. So it's kind of chicken or the egg, which started first. In my opinion, it really probably doesn't matter that much clinically, but in this study in 2006 to 2015, we find that in people who developed OUD, those really didn't have pain at 35% of the time. About 10% had OUD first and then developed pain, maybe treating, developing the OUD first. 40% had pain and then developed OUD. And so one could argue that they were maybe trying to treat their chronic pain. Maybe it was untreated or poorly treated. So patients who had chronic pain before the onset of opioid use disorder had high rates of other mental health disorders and other health conditions. And so that's why we really do have to kind of, within the context, be careful about using opioids for chronic pain. Patients who had OUD before the onset of pain were likely to have other substance use disorders, HIV and hepatitis C in the study. So now the management of chronic pain in opioid use disorder really, really should again be this idea that we want to use this biopsychosocial approach. And so starting with tier 1, self-management, starting with tier 2, then these other adjunctive therapies, and then using some of the pharmacologic adjunctive therapies as well. So we really do need to address, given the ubiquity and the prevalence of chronic pain in OUD, we need to address it because it can be a trigger for return to use of illicit substances. And so again, we talked about the comprehensive pain management strategies, and we'll talk a little bit more about how to maybe manage medications that we're using and maybe kill two birds with one stone. But knowing that, opioids, whether they be agonist, mixed agonist, they do have a limitation in how much pain. And then over time, just like tolerance develops in chronic pain management, it's kind of, an unfounded or a situation in which the pain relief will probably be lessened over time. So in the setting of acute pain, if required, we really do need to challenge the idea that if we give full mu agonists or opioid medications to a person living with opioid use disorder, that will worsen their opioid use disorder. And in multiple studies, 1980s and 2001, in folks on MMT, so for methadone and opioid treatment program, giving opioid analgesia in a setting of an acute pain crisis, does not worsen opioid use disorder. And so we do need to challenge that idea that, we're going to worsen. And certainly there's a lot of stigma, and I think, we have a long way to go with respect to treating acute pain in that setting, but it certainly can be done. And knowing that, if we don't do it, that we're really running the opposite risk now of increasing that risk of further worsening or risk of return to use. So the most challenging setting in acute pain management is when someone is on naltrexone. I really, for one of the reasons I don't really like, I think that's why naltrexone is a second and third line option really for OUD management. But in that setting, say there is an acute injury or need for surgery, we need to stop the injection. Obviously, we stop the oral administration. And then, there is a possibility that we need to now implement a mu agonist, and you can overcome the blockade, but it is tricky, and that would be really in the setting of anesthesia. Should we want to get them on board early? And so fentanyl can be titrated to overcome that antagonism, but then, really close monitoring, because now you're approaching that toxic and lethal dose, causing respiratory suppression. And in the setting, obviously, we still, similar to chronic pain management, we want to optimize the non-opioid management as well. You can use adjuncts, you can use the NSAIDs, and then if required, the interventionalists will get in and potentially put in an intrathecal epidural catheter, use regional anesthesia, and then potentially go all the way to ketamine infusions and lidocaine infusions. So there's a variable washout period with naltrexone, and so different people are going to have different metabolisms, and so watching, especially if someone is on a mu agonist, that would need to be titrated and tapered appropriately. One interesting, recommendation from Dr. Bott is that patients should always be advised to carry, alert card or a bracelet alerting, emergency physicians and personnel that they are on the medication. So much easier to treat acute pain in the setting of agonists and mixed agonist therapy. So a couple of different options. The first really option is to increase the dose of the medication, whether it be methadone or buprenorphine, and then change the dosing frequency to either BID, TID, or even QID. And so in the setting of OTP, that typically is dosed once a day. But if there's some take-home packages, take-home medications going home, then that can be now moved to a TID dosing. Generally, it's thought that both methadone and buprenorphine have about a 6 to 8 hour analgesic effect, whereas for the OUD cravings and withdrawal symptoms, that's more of a 24 to, methadone even longer, 24 to 36 hours for buprenorphine. So you can use a full mu agonist on top of both medications, both methadone and buprenorphine. And so it's kind of the idea that probably you're recruiting a subset of mu opioid receptors that aren't being utilized or aren't being occupied by methadone or buprenorphine. And so you can add some additional pain relief on top of that analgesia, keeping in mind that you probably need to use more than the standard kind of naive opioid patient. And so ideally, again, the agonist treatment is really just for baseline treatment of their addiction, and then kind of superseding and increasing the dose, whether it be the buprenorphine methadone or adding a mu agonist. Special note about methadone, as we know, in an opioid treatment program, it's not reported to the CSMD, and so if there's an inpatient setting and a patient will tell you their dose, typically what will happen is that you'll break that dose up into a TID or QID setting, and you monitor that dose and make sure that there's no kind of concerns about kind of overdosing. And again, like I said, you can add that short acting opioid for breakthrough. At discharge, very important to give a last dose letter. So a last dose of methadone prior to discharge so that they can take that over to their OTP and their provider can know how much they were given and at what time. So in the setting of buprenorphine and kind of an anticipated acute pain need, for example, surgery, the old way used to be to taper the buprenorphine down and then ultimately use a full mu agonist after the surgery. And that's typically not employed anymore. And I think what the better way and the new way that we're doing it now is to continue and maintain their standard dose of buprenorphine, and then either change the dosing frequency, change the dosing amount, and then potentially add the mu agonist after that. There can be some arguments that you can maybe decrease, not to zero, so taper a little bit of the buprenorphine, and then leading up to a surgery, keeping in mind that you're watching the withdrawal symptoms, you're watching for cravings and relapse, and then if we're doing okay, then we have a little bit more room then for increasing post-operatively, and that can sometimes help. But if we're really anticipating a very severe course, a complicated post-operative situation, or in the setting of hospice, really considering a transition over from buprenorphine to methadone, because we have a higher, we have that ceiling effect somewhat with buprenorphine, and so we can achieve higher levels of mu activation with methadone, and so that sometimes is a better way to go if kind of long-term and severe pain is to be anticipated. As I said before, again, it's really, I love the split dosing, and I really think it works quite well. And oftentimes you don't even really need to increase the dose of either medication, and simply changing it to QID or TID dosing really does help. So overall, in conclusion, we need to challenge the old paradigm of kind of ongoing acute pain similar to chronic pain. And we really need to kind of put it in the approach of a comprehensive biopsychosocial approach to chronic pain in the setting of OUD or otherwise. And that we really do need to treat chronic pain in opioid use disorder. And the opioids are the last, the last resort in chronic pain, but certainly can adjust medications as needed if we want to, kind of, so to speak, kill two birds with one stone. The full mu agonist can be added to regimens, especially acutely, and that, really naltrexone can be quite difficult to treat in an acute pain setting, and that we want to get our anesthesia colleagues involved early in that management. I think that's the majority of my talk.